All right, everyone, since it's 12 o'clock on the dot, I'll go ahead and start by introducing our speaker. So today we are glad to have Dr. Jacinda Abdul-Mutakabbir here to present to us. She's currently an assistant professor at both Loma Linda University School of Pharmacy and School of Medicine located in Loma Linda, California. Dr. Abdul-Mutakabbir is dedicated to magnifying and rectifying health inequalities in minoritized communities. She currently serves as a lead pharmacist and clinician for the Loma Linda University COVID-19 Equitable Mobile Vaccination Clinics. Her dedication to improving public health has been recognized by the United States Public Health Service, as she was a 2017 recipient of the USPHS Outstanding Service Award. She was also more recently received the Wayne State University Alumni Warrior of Distinction Award, the Society of Infectious Diseases Gita Patel Award, and was named one of the top 50 influential pharmacists by the Pharmacy Podcast Network. So without further ado, I present to you Dr. Jacinda Abdul-Mutakabbir. I don't know what's going on with the sound. I'm sorry.
Okay. Are you able to hear me now?
Yes.
Okay, sounds good. I was having some issues connecting the mic at one point. Okay, thank you, Janice. Am I saying your name correctly?
Yes, ma'am.
Okay, thank you so much for the introduction. Okie dokie, so I'm gonna go ahead and get started. Feel free to refer to me as Dr. Jam. I know that Dr. Jacinda Abdul-Mutakabbir can be a mouthful. So that's what my students call me and the community calls me Dr. Jam. So you all can too, I guess we're friends. So I'm gonna go ahead now and share my screen with you all. Okay. I always do this wrong, so bear with me. Alrighty, so we're gonna go ahead and get started. So making health equity a reality, the pharmacist's role in narrowing health disparities. So we'll get into that, but I really wanna focus on, in this first half of the presentation, just bring you all into my life and just explaining just my transition from, I guess, my early childhood into academia and just the many lessons and different situations and learning environments that I was in along the way. So I have no disclosures, but I always like to start this with a little game of two truths and a lie. So please choose from the following, and please feel free to put your choice in the chat box, and then we'll keep moving on. I'll pause for about a minute or so. I don't want to make this weird. So the first choice, I guess, is I'm a classically trained string bassist. The second is I was a model in a Paris Fashion Week fashion show. And then C is I am the youngest of three siblings. So feel free to pick which one you do not believe is true. Okay, C. I got some A's. Okay. I don't know if like the other two are so unbelievable that, everyone automatically assumes, okay, it has to be C. All righty, so I'll get moving. So just a bit about me, and let me know if you guys are seeing my notes or if I have to switch the way the displays look. That happens. So just a bit about me. I'm from Detroit. So I'm from the Midwest, born and raised. I grew up right on 7 Mile, just like Big Sean. For those that are familiar, so I was also a varsity cheerleader, like most everyone else that could cheer. I am also a classically trained string bassist. So whoever selected that one, that was not the lie. I do play the string bass. I also played the cymbals and marching band. And I am the eldest of three siblings. So that was the lie. And that's the one that everyone always picks. I'm not sure why it is that everyone is always aware that that is that is the one. I don't know. Maybe I give oldest sibling vibes, but yes, I am the eldest sibling. That's my younger sister and my younger brother below. They're quite younger than me. My sister is about 4 years younger than me, and then my brother is about 5. So they're close in age, but we're further apart. And then I have my parents, Bettina and Isaac Small. They are two of my very best friends. They are comedians. They are the best parents that I could have asked for, the most supportive, and I'm really happy to have them. And then I have myself and my husband. We actually got married when I moved back home for training when I completed my fellowship, which we'll get through. But we actually went to high school together. So I've known Raheem is my husband's name. I've known him since I was 14 years old. The funny story is we did not at all, date or talk in high school. We had adjacent friend groups, but that was about it. We ended up, in true millennial fashion, reconnecting over Instagram, and then we got married. So that is a photo of us at our wedding, and then my parents are right next to us, and they were also at the wedding. That's why they're in their nice attire. So for my undergraduate career, I went to the Howard University. So there we have the late and the super great Chadwick Boseman. We call Howard the land of the great Wakanda. So that was there where Chadwick received his honorary doctorate degree from Howard. A great day for us indeed. That was actually the year that my sister graduated from college. And I became a part of a Black Greek organization. So I'm a member of Zeta Phi Beta Sorority Incorporated. And these here are my sorority sisters, and my sorority sisters are also above us, as we were in a Paris Fashion Week fashion show. So we actually modeled for Rick Owens. For those of you that don't know Rick Owens, because I didn't know Rick until we actually stepped on the runway, because I mean, for what reason would I be wearing these expensive clothing? But he actually designs clothes for the Migos, Kim Kardashian, and Kanye West, and all of the celebrities. So we were able to walk in his clothes for free. So exciting. But he wanted individuals that were able to step, and that's what we do in our Black Greek letter organization. And one of my younger sorority sisters found the opportunity, and we ended up on an all expenses paid trip to Paris to model in Paris Fashion Week. And then I was also an engineering major for some time in college. I did not graduate with that degree. I actually graduated with a degree in sports medicine. And this is me, however, building bio sand filters. But this was my first introduction to health disparities, and my first real view of how it is that I wanted to interact with the community and be able to make life better and equitable for those around me. So that was my first experience there in Africa. It was truly a blast. I always think back to that experience and wish that I had taken it in a bit more when I was there. For my graduate experience, I went to the University of St. Joseph. It is in Hartford, Connecticut. It's an accelerated 3-year program, actually. So this is a photograph of myself. And then I'm in this picture somewhere. This is my white coat ceremony, actually, with myself and my classmates. And I guess another linkage there is the dean of, or he was the dean when I was at the pharmacy school. The founding dean of the pharmacy program was actually the interim dean at Howard when I was applying for pharmacy schools. So it was exciting to be able to have a bit of Howard there when I went to pharmacy school. I also chartered our Kappa Psi chapter there, Zeta Iota, when I was at University of St. Joseph. I hear that it is still standing strong, so I'm very excited about that. This is our beta class, actually, that I'm in a picture with. I'm at the bottom of the picture holding the K, and then the vice regent or the vice president is right next to me holding the Psi. And yeah, that was our photograph there. Very exciting times. And I think that mentorship is so important. And as you all are in pharmacy school, I hope that you have been able to isolate a mentor or find a faculty member that kind of models what it is that you want to do in your career and what it is that you see for yourself and things that you can imagine yourself doing when it is that you graduate from pharmacy school. For me, that was my infectious diseases teacher, actually, Dr. Dora West-Kirchen. So she's right here in the middle. And I have to make sure that I tell her that I keep her in these presentations. But she was so influential to me. And she really made infectious diseases so exciting for me to learn. And I was always so excited to be able to go into her class and see how she would explain the therapeutics aspect of the course. So she ended up becoming one of my mentors when I was in pharmacy school. And she's honestly continued to be one of my mentors before I make major moves. I always make sure to talk to her and consult with her and get kind of like her where her brain space is on the matter. And she's always been completely helpful. And I'm so thankful for her and thankful for that experience that I had in pharmacy school with her there, because she no longer teaches at the University of St. Joseph. They really are missing a gym there. And then this is a photograph of my parents, not in their wedding attire. So they are in their graduation clothes. This is when I graduated from pharmacy school. They're holding some of the awards that I received when I graduated for the program. But I'm always so excited about this photograph, because when I graduated from undergrad, I took that time to have a really good time and didn't really get any accolades when I was graduating. So I was happy to be able to share this proud moment with my parents. So I completed my postgraduate year one, or my PGY1 training, at the Howard University Hospital. So I went back home to Howard, and it was a wonderful time. I have a photograph here of myself and my co-residents. We're still very close, very good friends. We also have our residency director, our director of pharmacy. We didn't have a residency director at the time of this photograph. And then our critical care preceptor, Dr. Carly Stoneman. And they're all in that photograph with us. Howard was an amazing time for me. It really allowed for me once again to engage in infectious diseases, but to do so in a format that allowed for me to address and to realize and reconcile health disparities. Because for those of you that are unaware, Howard is it is the only hospital in the most urban area of Washington, D.C. So when we think about those patients that have HIV and different types of unique and endemic infectious diseases, we would see them a lot at the Howard University Hospital. And actually the pharmacists had their own clinic where they would see patients. And I was able to engage in infectious diseases in that way. And it was such a wonderful experience for me. I really loved it, and it really made me love infectious diseases, one, but it really made me love what I could do for the community when engaging in infectious diseases research and therapeutics work. So that's really where I fell in love there. And like I said, where I fell in love with research. So this is me with my first poster that I ever had for infectious diseases, for an infectious disease state anyway. And this was a medication use evaluation for daptomycin. I presented it at the Making a Difference in ID meeting in 2018. And I guess another unique or interesting linkage. Now I actually serve on the scientific committee for Making a Difference in ID, their youngest member there, and we reviewed other people's abstracts to see if we want to include them in the MAD ID meeting. So now I have this full circle moment where this was my first meeting, and now I'm able to help other people have their posters accepted at what may be their first infectious diseases meeting. So it's really a great experience, and I really enjoy it. And then I went on to complete a postdoctoral research fellowship following my PGY1 training. So for those of you that are unaware, as I'm not sure where everyone is in their learning careers, so you can do a PGY1, which is a more general residency, and then you can move forward and do a PGY2, which we know is a more specialized residency. Or in my case, I went ahead and I did a postdoctoral research fellowship. You can also do a PGY1, a PGY2, and then a postdoc. For me, however, Howard had provided me such a robust infectious diseases experience that I really didn't see the value at that time in me going to complete a PGY2 residency. So I went right into the postdoctoral research fellowship, where I continued to engage in preceptorship, and I was still able to go ahead and round with the team. So I still got a bit of a PGY2 experience as well. But I really wanted to foster and to build my research capabilities. For me to be an infectious diseases expert, I really wanted to know every single aspect of infectious diseases. I wanted to be able to really talk about and to own what it is that I was discussing and providing any type of influence or recommendations on. So I went and completed my infectious diseases in vitro pharmacokinetics and pharmacodynamics research fellowship under the tutelage of Dr. Michael J. Ryback at Wayne State University. So I went back home to Detroit, so my true home, where I did that. That was for 2 years. And I actually have a photograph here of myself and my co-fellows, once again, who have become family to me. We still maintain a really great relationship. All of us, we talk at least once or twice a week. And Dr. Ryback, we're all in this photograph here. And I always laugh and say, this is a very unique time where all of us are smiling at a single time. It never happened that everybody was happy at the same exact moment. But this was once again at the Making a Difference in Infectious Diseases meeting. There must be something about this meeting that makes everyone happy. And then this is me in a photograph. So like I said, I did in vitro research. And what I really wanted to see was using simulated human pharmacokinetics, so the way that the drugs perform in humans, can we see a difference in the pharmacodynamics or a difference in the killing of the resistant bacteria? Can we see that in these in vitro models? And if we do see this, can we go ahead and extrapolate our findings into actual clinical outcomes? So that's what I did here in the laboratory. This is a photograph of me conducting conducting an experiment for one of my first research projects. This project took me 2 years to complete, but it was definitely a joy in completing. So currently I am an assistant professor of pharmacy and medicine at Loma Linda University in Loma Linda, California. So actually, Janice, it is morning here where I am. It is about 9, hinging into 9:30 a.m. here. So this is a photograph of myself and my students. So I teach the P2 class, renal and respiratory diseases, and I teach the P3 class. So the P2 renal and respiratory diseases, the P3 class, I teach them infectious diseases. So I am the co-course coordinator of that course. I split that with my infectious diseases partner, and then renal and respiratory, I teach the respiratory aspect, but I coordinate the course for the P2s. So it is a joy to be able to see the students during 2 very big moments and in their teaching lives or learning lives anyway. I also practice in critical care. So I work in the ICU for about 8 weeks or so throughout the year. And then I am also the lead pharmacist for our vaccination community clinics, which is where you see me in these 2 photographs. And I also have an in vitro lab. So I wear a lot of hats there at Loma Linda, but it is always a joy, and it's a joy to be able to teach students in every different aspect of what it is that, or where it is that I work at Loma Linda. It's wonderful to see them grow in all of these different capacities and in so many different ways. So it's an honor for me to be an educator. I love it. I plan to be in academia for the duration of my career. So I'm happy that I enjoy it, but it is truly, it's truly been a life-changing and life-altering experience for me. So this is me, and then they were P2s at the time, so they were like my first class that I course coordinated because I began teaching in 2020. And these are my students, Lizette and Shasta, here in this photograph with me. We were at a community clinic. And then I have another photograph. So this is me once again at a community clinic, but at the community clinics, I don't just precept or take the pharmacy students. So I have pharmacy, dentistry, and public health, and pharmacy and medicine, and then the public health students are all represented here. In this photograph, we actually partner with faith leaders in the community to go and provide vaccinations for minoritized groups, so racially and ethnically minoritized groups, so our Black and Latinx community. And this is actually a photograph of a partnership that we had in the Black community, and actually with congregations organized for prophetic engagement, COPE. You see their banner there, but this is us at a vaccine clinic. I did have my mask nearby. I know I look like the problem there with no mask on in the photograph, but I put it right back on right after we took the photo. And this is me with the assistant vice president for community engagement, and then one of the professors of medicine. We provided a presentation to the students to really engage them in health equity so that they were aware of what it is that we do when we talk, or what we mean when we talk about health equity, which we will continue to move into throughout this presentation. But I think that it's so important for students to see professors of color that go out into the community and really work to make healthcare something that is accessible for everyone. And they awarded us with these certificates after the presentation, of which I still plan to frame. So an overview of my research, because at the core of who I am is a researcher. That's what I do. And I have two arms for my research, which I'm sure you all picked up as we talked about the postdoctoral fellowship. And then we moved into what it is that I do now in the academia space. So one thing that I didn't mention is that in my postdoctoral fellowship during that time, I also received a master's in public health, which was amazing for me to do in my hometown of Detroit. It allowed for me to see Detroit in a completely different lens, which really just impacted how it is that I view public health, how it is that I view health equity, because it really made a lot of things that were inequitable in Detroit that I didn't realize, of course, as a child or having been familiar with the city. It made it tangible, and it made it so that I could see what it was that I wanted to impact when I continued to move forward with my career. So I do a ton of research in infectious diseases. I do a lot in terms of antimicrobial stewardship. I do a lot in multi-drug resistant infections. So by multi-drug resistant, what I mean is those infections that don't respond to our typical therapies of antibiotics that we would normally use. So I do a lot of research there. But then I also do a lot of research when it comes to health equity, when it comes to vaccine equity, and when we think about utilizing different tools in the community or to go ahead and engage the community in being vaccinated. When I think about vaccine equity and antimicrobial resistance, I think about the fact that, for one, individuals of racial and ethnic minoritized groups are more likely to perish or we see more mortalities there in those individuals amongst those groups that are unvaccinated. So they typically do not receive the vaccines. And because they do not receive the vaccines, they are more likely to die from vaccine preventable disease states. So when we talk about influenza, when we talk about when we talk about bacterial pneumonia, things of that sort, because they don't receive those vaccines, and that's due to medical mistrust and other variables that contribute to that distrust and mistrust of the United States healthcare systems. Nevertheless, when we think about secondary or co-infections that can come along with these vaccine preventable diseases, we think about multi-drug resistance, right? So of course, we don't have literature that backs this up, and this is something that we definitely need to key in on as infectious diseases researchers. What we can extrapolate is that these individuals are more likely to suffer from these vaccine preventable infections because they do not get vaccinated, then we can loosely say, or we can loosely infer that these individuals are more likely to develop secondary or co-infections. And with these infections, they may be more likely or more susceptible to multi-drug resistance. So now I'm working on tying both ends of my research together to really emphasize and increase health equity and vaccine equity. And when we think about antimicrobial stewardship equity, I want to make this clear and something that we really try to attain in infectious diseases, something that we really ring the alarm on. So I also want to, before I get into this presentation, just talk about the fact that I know that a lot of times as investigators of minoritized backgrounds, we often end up in this place where health equity is kind of what we are expected to do. However, I never compromise my science. I never compromise the fact that I am an in vitro researcher, because I want to emphasize that individuals of minoritized backgrounds, and more than anything, that women can do research in every single aspect. So my research, when talking about my my in vitro aspect and antimicrobial stewardship aspect, is focused in antibiotic combination therapy. So our rationale for combination therapy is that it broadens the microbiological spectrum of activity. It may allow for us to use lower doses of the antibiotics. We can get synergistic activity. What I mean by that is in this photograph. So 2 antibiotics may work better than either agent works alone. And then also using 2 therapies has been shown to bolster the host immune response in infection. So we get a lot of advantages when we use combination therapy. So with this idea, what I do with the multi-drug resistant, or those bacteria that won't respond to the monotherapies or the single therapies that we use, I go ahead and try to figure out what's a sweet spot with multiple antibiotics that I can utilize to try to go ahead there and maximize the activity that I'm seeing. So here I have my first research project that was really mine. So this was the grant that I submitted with my principal investigator, Dr. Ryback, and then it was funded by the drug company, which is Shionogi, that has ceftriaxone, which is actually one of my favorite antibiotics. It has a novel mechanism, so it's a siderophore, but it's attached to a cephalosporin. So it uses the active transport of the bacteria, because we know siderophores are iron chelated moieties. So they attach to iron and then they move into bacteria, because bacteria also need iron to survive. So the bacteria, when they see the siderophore, they think, oh, iron's being brought to me, but what it really is a cephalosporin that looks a lot like ceftazidime or cefepime being brought to the bacteria, but it's bypassing all of those systems that bacteria typically have to go ahead and potentiate resistance. So it's such a novel mechanism, such great activity there. And I wanted to test ceftriaxone alone and then in combination with other antibiotics. And the gist of the experiment was that essentially I did see activity with ceftriaxone when I use it in combination with other agents. But more than anything, I want to emphasize that I was the only woman that was on the bench doing research with this drug when we were presenting this to the drug company. And I was the only Black woman that was here doing research with this drug. So this was a very big moment for me, but it made me really take ownership of my research. It made me value what it is that I could contribute to research, but it also allowed for me to know that I could do research in this way, that I could represent not only my community in this way, but that I could represent women and Black women in this way. So I was very honored to do that. I still work with this drug actually to this day. It's one of my favorite antibiotics to utilize. And I actually memorialize this experience with a tattoo. So I did get a siderophore that's specific to ceftriaxone and Acinetobacter. So it was a wonderful experience. And then, so now I have my other project that I did, and this was a 2-year-long labor of love project. So it was definitely a longer project than the ceftriaxone project. But I think what it taught me is that research is not easy. Research often calls for you to take a step back. It calls for you to reassess. I rewrote the manuscript that I actually utilized for this project at least 3 times and submitted it to my principal investigator each of those 3 times. And while, it seemed like I would never get the project done. It seemed like my data would never be something that we would be able to actually find value in. We were able to get the paper published when I left the fellowship. And we were able to do that. I was able to do that mostly on my own there. And I was able to go ahead and really take ownership in the results and be able to navigate my way around the explanation of those results. And also more recently, the manuscript was actually utilized as a literature component or a reference for the IDSA MDR gram-negative guidelines. So not only was this a long project that I felt like I would never find that I felt like people would never find value in, it actually was something that will continue to guide the way that we utilize therapeutics in multi-drug resistant gram-negative infections. So I say all of this to say, you may be working on something that may seem hard, you may not see the point in what it is that you're doing, but there is a light at the end of the tunnel, and you never know where it is that your work will be utilized or where people may find value in it. So I have just here, you can find me, and I hate to say this, I'm not Beyonce as much as I think I am, but you can find me right on Google. If you type my name in, you can go to my Google Scholar, and there you can find any of the manuscripts that you all may be interested in. I do have publications, of course, in vitro studies, antimicrobial resistance. I focus a lot on Acinetobacter, gram-negative pathogens, but then I also do a lot of equity work and work discussing women in pharmacy and Black women in pharmacy and things of that sort, and pharmacists in health equity. So feel free to go ahead and take a look at the research articles. So now I want us to lean into my health equity arm and to really put health equity into this context of the photograph on the right. So when I talk about health equity, I often get that question of what's the difference between equality and equity? So equality means that everyone is able, or everyone has the ability to do. Everyone may not have the same type of access. Everything may not be easily attainable for everyone, but everyone has it. So when we think about healthcare, everyone could get healthcare, but is healthcare accessible for everyone? No, we know that that's not the case. When we think about the vaccines, well, there are pharmacies that provide the vaccine. So technically there are places where people could get the vaccine, but is it equitable? Meaning, can they easily take off of work and go get the vaccine? Are the pharmacies close to where they live? Do they have the transportation to make it there? So that's the difference between equality and equity. And we can see this with the bicycles. Everyone has a bicycle, but is the bicycle exactly fitted to their needs? What we see at the bottom when we think about equity, the bicycles are perfectly fitted to everyone's needs and they're able to actually enjoy and really lean into that experience. So let's put this into the perspective of COVID-19. So COVID-19 is just that very clear view of seeing how healthcare inequities have permeated through our racially and ethnically minoritized communities. So first and foremost, we know that Black individuals, Latino, and Native Americans represent a combined 60% of COVID-19 deaths, despite comprising significantly less of the United States population. However, this is due to systemic practices that have placed them at a disadvantage for equitable healthcare. So these morbidities that cause an increase in death are prominent amongst these groups. We know that the vaccines are available and they are able to change this inequity. But we know that at the end of the day, as we previously discussed, due to the long history of mistreatment within the United States healthcare system, there's just a large decrease in the trust for the system to use the fair practices for these individuals when they get vaccinated. So they're less likely to go ahead and get the vaccine, which then continues to propagate just the increase in COVID-19 related deaths that we see here. And then for those that do want to be vaccinated, you have the fear of the cost associated with healthcare that keeps them from going ahead and getting that vaccine. And then also those inaccessible signups and then the Wi-Fi that's mandatory that continue to create those barriers for access. So we recognized this, and then at the time in which we began our vaccine clinics in California, there were about 17 million individuals that had been vaccinated or that had received one dose of the COVID-19 vaccine. Nevertheless, only 3% of Black individuals had received that vaccine, and that is far less than what they comprised of the hospitalizations at the time of COVID-19, and also less of what they comprised of the San Bernardino County in California as a whole. So Loma Linda University had the largest mass vaccination clinic site. And at that time, we only saw that about 3% of the individuals at the mass vaccination clinic site were Black individuals as well. So we continue to just see this disparity. So with that, we knew that it was important to develop these concentrated processes that would go ahead and increase or overrepresent the Black community, which is what we wanted in terms of vaccinations. So we created these tiers to go ahead and increase our approach for promoting equitable vaccine access. So our first tier was the engagement of Black faith leaders. Our second was the delivery of COVID-19 fact-based information from a Black pharmacist. And then our last was our low barrier community clinics, which we really tried to attack the previous barriers mentioned. So we began our engagement with the faith leaders by describing to them what the vaccines were and really pulling them on board with what it is that we wanted to do in the community. And then after that, we were able to go ahead and conduct what we call faith summits, and we've now began calling them town halls so that we can present them as inclusive and have those individuals that may not necessarily identify with the faith actually join into these informational webinars as well. So we have Dr. Juan Carlos Belliard and Dr. Bridget Petit. They are the Assistant Vice President for Community Engagement and a psychologist respectively. And they come on to these webinars with myself and we talk about the vaccines. The webinars begin with Dr. Belliard describing the impact that that COVID-19 has had in these minoritized communities. And then Dr. Petit talks about the psychology behind being vaccinated and why it is that people of minoritized backgrounds may not want to be vaccinated. And then I round out the presentation where I give just fact-based information about vaccines. I talk about the clinical information pertaining to the COVID-19 vaccines, but I make it specific to minoritized groups because I know it's important that these individuals feel safe. They know that they're accounted for, and that we just explained that what the Tuskegee experiment was, or the misuse of the Black and Latino and Native American communities, is something that did not happen in these vaccine trials. And I want to make sure that they are aware of that. And then we go ahead and we round out these presentations with the survey, because we want to know, was the information that we provided, is it something that is going to increase the likelihood of these individuals in being vaccinated? When we begin our presentations, we have about 50 to 70% of individuals that are willing to be vaccinated before they receive any info. At the end of our presentations, we are able to increase that to about 90 to 93% of individuals that are willing to be vaccinated after hearing the information that it is that we provide. So we gave our first summit in February. We have continued to do so, if not monthly, bi-monthly, with the FACE summits. We actually have one coming up in a few weeks before we go forth and do an additional booster clinic. So we have continued to stay involved with communities to increase the trust in the foundations that we created there. And then we go ahead and we do a low barrier vaccination clinic. So we actually take that team that I showed you all with the FACE summits, they come with me, and we do these low barrier community clinics. We wanted to make sure that we addressed each of the barriers that I brought up previously. So access, meaning we bring the vaccines into the community. We address transportation, because we hold those vaccine clinics right there in the heart of the communities, right there in the urban locations where people can take the bus, they can walk, that it's easy for them to get to. And then we take away the internet and computer access aspect of it. We have a walk-up clinic, meaning that we have paper-based registration. So all of the necessary fields that have to be completed before we can enter the things into our computer system, they're right here on this sheet of paper that individuals can fill out. And we make sure that we have this also because we get people that still continue to have questions that, or may be hesitant, and they want to talk to me or talk to another clinical professional there to go ahead and guide that conversation, or to use that time to go to figure out whatever it is that may be keeping them from getting the vaccine at that very moment. So I have that combo with them, and thankfully we've been able to go ahead and bring a lot of people to the vaccination side after we've taken the time to talk to them. And that paper-based form has allowed for us to do that because we don't have to shift any appointments. They just hand us the form and we go ahead and we do the clinic. So I always like to talk about our stakeholders because it's easy to see, you know, the FACE Summit, is easy to see the community clinics, but it's harder to kind of conceptualize who is it that's necessary to make these things work. So our faith leaders are who I attribute, honestly, 100% of our success to. They have been just so impactful, and I'm so thankful for everything that they've done for us and the support and the trust that they placed in us. And then that has essentially led to the trust and the faith that their community has in us to do what it is that we say that we're going to do. And that's honestly led in the turnout of the vaccinees that we've had at these clinics. So we appreciate and trust and love our faith leaders so much that we actually included them in our publications that we have written about these vaccine clinics. They have actually served as the second through fourth authors throughout those manuscripts that we've sent, and we've done international presentations and national presentations, of which they have continued to be a part of, because so often we write about the community, but we don't actually include the community and when we tell that story. And then we have pharmacists. So myself, I serve as the face of our clinic. So I precept the students. I make sure I check the vaccines before they go out into the community. But I also have additional professors from the School of Pharmacy that join me at the clinics. And we also have other pharmacy staff that may come and join at the clinics as well. We have the students, we have pharmacy interns that come into the clinics, we have the medical professionals. So we have a lot of medical professionals that are in training. As I told you all, we have physicians, nurses, dentists. We actually also had a respiratory therapists that all come to these clinics and they come be a part of this effort. We have our community health workers, our church volunteers, who are so important because they're able to go ahead and help their community members through the registration processes or when they're leaving, but they also create that air of familiarity, right? So they allow for the members coming there to be vaccinated to feel very comfortable when they're there. We have our administration personnel who take care of all of the logistics of the clinic, and then of course our supply chain management that ensure that we are able to order all the necessary supplies. And I 100% attribute our success that we see in these clinics to the students. So along with the faith leaders, we have our students there that have just been so important. But more than anything, students are important to our sustainability. At the end of the day, we want to continue to see these clinics, we want to continue to see the growth in these clinics. We want to continue to build empathetic pharmacists, and we want to just ingrain this health equity, this idea of health equity into the constitution of these learners that we have. So I know when I was in pharmacy school, learning about social determinants of health was not something that was not something that we truly engaged in when I was in class. And then I didn't have tangible experiences. So we work hard to create that for our students here at our clinics. They are completely student-based in terms of the vaccinators. So it's me there as the clinical preceptor, but we teach the students how to vaccinate. Oftentimes it's their first time there at a vaccine clinic, especially for our medicine students. But we treat this as a learning experience for them as well. And then of course, is it a real clinic if we don't have measurable outcomes? So I do want to show you all the data from our first vaccine clinic. We vaccinated, so at our mass clinic, we had vaccinated 17,000 or so individuals, but as you can see, only 3% of those individuals were those that identified as Black. And then when we went into our mobile or our vaccination community clinic, we were able to vaccinate 420 individuals, but 83.5% of them were Black. So we did exactly what it is that we wanted to do in the Black community. We overrepresented that previously underrepresented group. And then we have gone forth to conduct more clinics. I'm actually doing a clinic in the next 2 weeks. We're now in the booster phase of our clinics. We've vaccinated over 2,500 individuals against COVID-19 within the community. So this is work that we did and we're continuing to do. And we've also begun to reproduce our vaccine clinics in the Latino community as well, utilizing the tiers that we developed previously in the Black community. So I like to talk about just our first dose clinic, our first dose Moderna clinic that we had in the community. We vaccinated 258 individuals in the primarily Latino community. When we went back for that second dose, we vaccinated 253 individuals. So about a 97 to 98% return rate, but more than anything, when we vaccinated them, we had so many individuals come back and actually tell their family members to come for a first dose. So we were able to give some first doses at this vaccine clinic as well at the second dose. So we ended up vaccinating somewhere around 280 individuals, but the remaining numbers were those that received first doses because they were so excited about being able to have access to the vaccines there. And as we think about health equity, and I won't spend a ton of time with this, I won't spend much time here with this data, but I do want you all to see just the differences and the vaccine uptake that we saw and the differences that we see amongst racial and ethnic groups. I know a lot of times when we listen to the news or when we do research, we see the same approach being utilized throughout each minoritized group. But I want to emphasize that we have to make sure that when we develop these equitable processes, that we're ensuring that every single aspect that these groups need is being covered throughout our approach. Meaning for us, we had kind of augmented our tiers, and we took those tiers to go ahead and serve the Latino community, the tiers that we developed for the Black community. But it was important for me to take that step back and say, okay, but are we doing exactly what we said that we wanted to do? In the Latino community, are we seeing the same amount of Black individuals? Because when we're in the Black community, we see a good showing of Latino individuals, but but then I saw we were not seeing that with the Latino community when it came to the Black representation. We weren't seeing that that increase of Black individuals. So it showed me that I had to make sure that we continue to foster the trust and relationship with the Black community. It wasn't just a matter of they need access to these vaccines there. No, they need to have that trust and relationship. They need to know that we're going to take care of them and that we're there for them in terms of the vaccination process. Not that the Latino community doesn't need that as well, but we know that accessibility was really a major issue when we went into the Latino community. It was very hard for them to have to go to the pharmacies to go get the vaccines. The pharmacies were very spread out. There were no primary care provider offices that they could go into and be vaccinated. So for future directions for our community vaccination clinics, as I previously described, this is by no means a one and done thing for us at Loma Linda, or a one and done thing for me when I think about health equity. As I described, antimicrobial resistance is a big focus for me, but when I think about that, I think about vaccine preventable diseases, and I think about the fact that Black and Latino individuals continue to be those that die at disproportionate rates, or that develop these secondary or co-infections caused by these vaccine preventable diseases that can go ahead and translate into the continued propagation of antimicrobial resistance. So we're using the infrastructure that we have built, the trust that we built with these COVID-19 community vaccination clinics to go ahead and do more clinics. So we're hoping to increase the amount of the amount of vaccines that we're able to provide in our clinics. We want to provide information about HIV because those vaccines will become available at some point. We want to provide rapid testing for HIV. We want to continue to utilize this foundation we've created to bridge that gap, to create that trusting infrastructure, and to mitigate these health disparities in every single way that we can. So just bridging the gap, I do want to emphasize that once again, as a Black woman with interest in both health equity and also in vitro science, I always make sure that I try to marry the two. But I'm excited to be able to receive awards and to receive support, or to receive the acknowledgement of the fact that people understand that you can wear two hats when it comes to research. You can have different arms of your research. You don't have to just key in to one aspect. And there are different ways that we can go ahead and do better for our communities. And that's the very last thing, and the only thing that I want to make sure that you all take from this, that don't think that anything is too big for you to attain. You can do whatever it is that you put your mind to. And pharmacists are just so important in so many different ways to mitigating health disparities. Thank you.
Dr. Jam, we just like to thank you so much for coming in and speaking to us, and really showing our students the different things that you do, and well, showing all of us because you look and you'd say these are very different areas of research, but you can tell that you have a great passion for both of them, and just to remind us that if we have a passion, we should go for it, and the impact that we can have on our community. So we're very grateful for that, and for you getting so early in the morning for you. Nice time in the afternoon for us to come and chat. We always, this East Coast, West Coast thing is more than just a rapper debate. It becomes an issue anytime that we're trying to get together and do presentations. So we really do appreciate that. And definitely, want to find some, other opportunities to learn more and more about you. And hopefully when all of this, these COVID things end, really try to find some time where you can meet with our students, personally, because I think you will have impacted them a lot. So does anyone we have some minutes, a few minutes. Does anyone have any questions for her? And I see that the big boss, which would be our dean, has his hand up. And so therefore I will allow him to speak first and just go idly into the background. So, but again, I'd like to thank you.
Thank you. Thank you.
Thank you for a great talk. Um, it raises a question that I have had for a while that you might be able to answer, which is, having done clinics targeting both the Black community and the Latinx community, what do you think about the necessity for or approaches to basically tuning the outreach approach and materials to individual communities culturally, as opposed to using a generalized sort of outreach approach?
Right. So I think the one, that's a really good question, Dr. Guy, thank you. But I think the one thing for Loma Linda is we have that, it is in a community, it's in San Bernardino County, which is majority Hispanic and Latinx. So it's easy for us to translate the material, but we also work with two major groups. So we work with the communities, and I had to condense the presentation. I have a presentation where I'll talk exclusively about that. So if you guys ever want me to come back, but I had to condense. So we work with the congregations organized for prophetic engagement, which is our Black pastors in the Inland Empire of concerned African-American churches. And then we work with El Sol, which is our Latino community. So we work with two different groups, and we target our we target our materials through those two different groups. So with El Sol, they have specific material that they need, and so I'll do a lecture or something for them, and they will have someone there that will translate the lecture or any materials that we develop. The El Sol people will be in charge of it. So they run like the banner with like translation right there. Or I've also been able to refer them different Latino and Latinx providers that they can use. So then they'll use them, but we have the same information. So we'll be delivering the same material just from different representations of the community. So we try very hard to represent the communities when we go there. Because I'm the one that's doing like all of the lectures and all of that, it ends up being me a lot of the time. But what we will do is make sure if we have any videos or any material that we want to hand out, that it is translated, or that in the videos we have someone that's representative of the Latino community when we do conduct those. But we do a lot of translating, we do a lot of collaboration, and we make sure it's specific.
Does anyone else have any questions?
I do. This is Linda Dwascom. And this question may be off, I don't know, but I was thinking, I mean, have you thought about stretching further? There's so much going on in the world, and it seems like a lot of the problem is in other countries, even more than our country, that so that other variants don't come about, that we can increase the ability to reach people. And have you thought about how what you've done so far translates maybe to other countries?
Yes, absolutely. So we've actually, we just received a grant to do some work in Sierra Leone. So we'll be teaching their community just how to go ahead and deliver the information and engaging their community health workers so that they can increase vaccinations amongst Sierra Leone. But I mean, if it were up to me, I would take the vaccines with me and go ahead and go across the border to Mexico. But unfortunately, we aren't able to take the vaccines out of the country yet. But the minute that we are, and the minute that that's something that the White House kind of gives us the nod on doing, I've been talking to my dean, who was actually a part of the CDC vaccination team. So fingers crossed that we can be international. But that is my hope. So we have the grant with Sierra Leone, but I mean, I agree with you. At the end of the day, global equity is what, until global equity exists in terms of the vaccine, so global vaccine equity, we will never see a cessation of COVID-19. We won't ever see a decline in variants, because that just won't be the case. There'll be people that travel, that come back and forth. I mean, it has to be a priority, and it's a priority to me, but I mean, just with the governmental limitations. But I hope that, we can definitely get the word going.
Yeah, well, I'm really glad to hear that you're, stretching and trying to go further, and, maybe, I don't know, maybe interacting with the World Health Organization or something like that, and showing them what you've done, you might have an even bigger traction. You know, I mean, that's not my area by any means, but just trying to think big and solving these problems.
Right. Well, if anyone has any connection, I would
Maybe
love.
Dean Guy does. He seems to be well connected all the time to me.
Dr. Guy.
Indeed,
let
and
me
I'll
know.
pass some on.
Sounds good to me. But yeah, I would be honored to do so. But I agree 100%.
We have a question from one of our wonderful students in the chat. So our student asked, are there any other prominent minority groups in your area that you have plans to create targeted vaccine clinics for?
So it was my hope to go into the Native American community and to do vaccinations there. It just ended up, we weren't able to coordinate the way that I would have liked to, so we weren't able to go there. But I hope to go to every single racially and ethnically minoritized community and to find a way to increase vaccinations amongst those groups. We have a very big Cambodian community here as well. But I also have that limitation of, and then we have the limitation just amongst the university. We don't really have a lot of, and that's just a limitation in healthcare, right? We don't really have a lot of Cambodian individuals that are in healthcare at the university. So it's hard to be representative the way that we have been in the Black and Latinx, same with the Native American community. So it's hard for us to create those relationships. A lot of the relationships have come from the fact that Dr. Belliard is Latino, so he's able to communicate with the Latino community. I'm a Black woman. Dr. Petit is a Black woman, so we've been able to talk to the Black community. And then because I worked so much with the clinics, the Hispanic community has also become very comfortable, and the Latino community, they have also become very comfortable working with me as well. But it's harder to go into different communities where we don't have the representation, where we don't have kind of that bridge and the access. So that's been harder, but it has definitely been my hope to go ahead there and to be able to engage with them in some way. I have sent the Native American community, though, the videos that I developed. So I do have a video on YouTube that provides COVID-19 information, and I have sent them that video to hopefully disseminate amongst their community. So I'm trying to help in any way that I can, but it's been hard. I will be transparent in that.
I see the dean still has his hand raised. I'm trying to see if he has an additional question or comment. I think there was a head check. Oh, he forgot to unraise his hand, so lower, I guess is the better word for that. Let me see. I see a thank you. It's important. You have a whole lot of thank yous, FYI, in the chat, and a whole lot of people.
Oh, thank you.
Brilliant. And I will add to that you are brilliant and you're wonderful. And we're thankful to what you're adding to our world. And so we are at time. I just again want to tell you that we appreciate you, and we'll contact you again. Janice is saying, would you like to come back? So we're begging for your return. I will say that I agree with that as well. So we really do appreciate you taking this time with us. And again, we do hope to see you again. And Tam, I'm sorry, we're at time, but we'll let you get the question through. All right. Thank you so much, Dr. Jam, as you like to be called. We appreciate you.
Thank you. It was a pleasure. Thank you so much for having me. Thank you.